Welcome back, everybody, to our new episode for today about the coronary artery disease or ischemic heart disease. So, let's start things off with a general background. This is the heart with its four chambers. If we take a part of the left ventricle wall here and look more closely, it will show us three layers. The inner part is the endocardium. The middle part is the myocardium, and the outer part here is pericardium. And the pericardium consists of two parts, visceral pericardium and parietal pericardium. And between them is the pericardial cavity. We're going to talk about this later. The heart muscle is like any other muscle of the body. It needs blood supply to provide oxygen and nutrients, especially during stress or exercise. The more the heart pumps, the more blood needed. The heart muscle gets its blood supply from the coronary artery. So anything that would reduce the blood flow of the coronary artery, most commonly atherosclerosis, will ultimately affect the heart muscle and cause supply-demand mismatch. Depending on the severity and the duration of the ischemia, we will have a range from stable angina to myocardial infarction. Let me explain. Let's imagine that this is the coronary artery lumen, and over time, there is a gradual accumulation of lipids reducing the blood flow. If this plaque obstructs more than 70% of the lumen, we will have something called stable angina, which means during rest, the heart muscle gets enough blood supply through the open 30% of the lumen. However, during times of stress, when the heart pumps more, this open 30% cannot meet the increased demand of the heart, and the patient will experience chest pain. Keep in mind that this ischemia is not severe enough to cause death of the myocardium. Moving on to the other extreme. If we have severe obstruction of the lumen, it will cause myocardial infarction, which means that the ischemia is severe enough to cause death of part of the myocardium. The left ventricle is more susceptible to ischemia than the right ventricle. And this is because the left ventricle pumps the blood to the whole body against higher blood pressures. Therefore, it's more muscular and needs more blood supply than the right ventricle, which only pumps blood to the lungs against lower blood pressures. The most vulnerable layer to ischemia is the subendocardium, the inner third layer, and this is because of its location furthest from the supplying arteries. In case of acute myocardial ischemia, we have decreased ATP in the myocardium, and this makes the myocardium unable to relax, and the walls become very stiff, and the ventricles cannot really contract well. This is reversible within 30 minutes. Otherwise, the myocyte death will occur, which is called myocardial infarction. When you acutely decrease the blood flow to the heart, something called myocardial stunning sometimes happen. And this means that there is a transient left ventricle systolic dysfunction, meaning the left ventricle cannot really contract well and pump blood to the whole body. Fortunately, this myocardial stunning is reversible after reperfusion when you restore the blood flow to the heart. In case of chronic myocardial ischemia, the heart does something really smart, which is called myocardial hibernation. Just like hibernation in animals in winter, when temperatures are low and there is not much food resources around, some animals go into this hibernation state to decrease their body demand of food and nutrients till the weather becomes suitable again. The same thing goes here for the heart. When blood flow decreases gradually, the heart decreases its contractility and metabolic demand to meet the decrease in blood supply and prevent myocyte death. And when this happens, we have left ventricle systolic dysfunction, but this dysfunction takes months to reverse. And you can compare that to myocardial stunning, which is almost completely resolved or reversible after reperfusion. If myocardial death happens, as in myocardial infarction, we will have decrease in contractility that is irreversible. This contradicts with what happened in the last two examples. In myocardial stunning and in myocardial hibernation, it was reversible decrease in contractility. However, here in myocardial infarction, it's not reversible. The second point I want to make is that the dead myocytes release their contents, also known as cardiac biomarkers like troponin 1 and creatinine kinase MB, into the blood flow. So we use these biomarkers to diagnose MI or myocardial infarction, because if they are high in the blood, that means that myocardial infarction happened. So the first is cardiac troponin 1, and this increases after 4 hours and peaks after 24 hours. And the important point is that it lasts for 7 to 10 days, and it is more specific than the other biomarkers. The second one is creatinine kinase MB. This increases after 6 to 12 hours and peaks after 16 to 24 hours, and it is less specific and it returns to normal levels after only 2 days. So it's useful in diagnosing reinfarction following acute myocardial infarction rather than diagnosing the acute myocardial infarction itself. Moving on to the EKG changes in myocardial infarction. So the earliest sign will be hyperacute or peaked T wave. The latest sign will be deep Q wave. The other important thing to know here is that in case of completely obstructing thrombosis, this will cause complete wall infarction, which we call transmural myocardial infarction. And the hallmark of this is that it causes ST segment elevation, and we call it STEMI. Another point which will come naturally to you: if partial obstructing thrombosis happens, this will cause partial wall infarction. And the most susceptible layer to infarction, as we said, is the subendocardium, the inner third layer, and this will cause ST segment depression, not elevation. And in that case, we call it non-STEMI. Now let's talk about coronary artery disease risk factors. So the way I remember this is to start with increase of 4 things. Increased blood pressure, as in hypertension, and this is the most common risk factor. The second one is increased blood sugar, as in diabetes mellitus. Third is increased blood lipids. Fourth is increased age, old age. And we have things like family history, male gender, and smoking. And smoking cessation is the single most important intervention to decrease the risk of myocardial infarction. Now let's talk about the typical chest pain or typical anginal pain. The location of the pain would be substernal, meaning in the middle of the chest, not on the left side as you would assume. It's in the middle. The quality of the pain is it's burning, squeezing, or pressure. This pain can radiate to the left arm, shoulder, neck, or jaw. And this is because of the shared sensory neurons in the upper thoracic dorsal root ganglion. We call that referred pain. There is no changes with position or palpation. Autonomic symptoms may be present, like diaphoresis, cold sweats, syncope, palpitations, nausea, and vomiting. Now let's apply the knowledge we gained here into the specific diseases that we're going to talk about. So the first one is stable angina, and this happens usually due to atherosclerosis that obstructs more than 70% of the coronary artery lumen, as we said. The anginal pain here lasts for 3 to 15 minutes and increases with exercise and emotional stress. Pain is relieved by rest or nitroglycerin. As we said before, no infarction equals no increased cardiac biomarkers. EKG changes will show possible, it can happen or not, ST depression and or T-wave inversion. The second one we have here is unstable angina. And from its name, unstable means unpredictable. And as you can see here, it's more severe than the stable angina that we talked about. The unstable angina happens usually due to an ulcer that happens in the atherosclerotic plaque, and a secondary partially obstructing thrombus happens. The anginal pain will happen at rest or minimal exertion. And as we said, it's not predictable. Episodes may be longer, pain may be worsening, the frequency of the episodes may be increasing and not stable. And again, no infarction equals no increased cardiac biomarkers, and EKG changes are basically the same as in stable angina. Now let's talk about non-STEMI, and this is myocardial infarction. However, the obstruction here is partial and the infarction here is partial, and both of these will represent ST segment depression in the EKG changes. Anginal pain will be not predictable, occurring at rest, and is not relieved by nitroglycerin. The pain is severe, persistent, or worsening. And infarction happened, and this equals increased cardiac biomarkers within 1 to 6 hours. And as we said before, troponin 1 is more specific and it remains high for 7 to 10 days. CKMB is less specific, returns to normal after only 2 days, and it's used for diagnosis of reinfarction rather than the acute myocardial infarction itself. Now we can predict the STEMI. STEMI is completely obstructing thrombus, causing completely wall infarction, transmural infarction. And this would show ST segment elevation. And the anginal pain is similar to that of non-STEMI. And of course, infarction happened, meaning increased cardiac biomarkers. To make things easy, let's compare the 4 diseases we talked about so far in a table. First, stable angina is due to atherosclerosis plaque that's obstructing more than 70% of the lumen. Unstable angina is due to partially obstructing thrombus that's causing ischemic symptoms but not severe enough to cause infarction. Non-STEMI is due to partially obstructing thrombus that's severe enough to cause subendocardial infarction or partial wall infarction. STEMI is due to complete obstructing thrombus, which will cause complete wall infarction. The anginal pain here, or chest pain, in the stable angina, it's predictable and it lasts from 3 to 15 minutes. It increases with exercise or stress, and it's relieved by rest or nitroglycerin. In unstable angina, chest pain is not predictable. It can occur at rest or minimal exertion. In non-STEMI and STEMI, pain is basically the same. It's non-predictable. It occurs at rest and it's not relieved by nitroglycerin, and pain is severe, persistent, or worsening. Cardiac troponin, of course, in the angina, whether it's stable or unstable, cardiac troponin is not elevated, whereas in myocardial infarction, whether non-STEMI or STEMI, it's elevated. EKG changes. As we said, possible ST depression and or T-wave inversion. In non-STEMI, ST depression happens, and or T-wave inversion. In STEMI, ST elevation happens or new left bundle branch block. And we're gonna talk about this later. Now let's talk about a disease that's related to those four, however, it's very different in its cause. It's called vasospastic angina. The reason it's really different because it's not due to an obstruction like those four diseases. However, it's due to vasoconstriction of the coronary artery. So the coronary artery constricts on its own because of hyperreactivity of the coronary artery. And the pathophysiology behind that is because the endothelial lining of the coronary artery is faulty. It has a lot of hyperactive alpha 1 receptors, which causes vasoconstriction, as we know. And it lacks or has low levels of nitric oxide, which normally causes vasodilation. So we lack that and we cause vasoconstriction instead. Vasospastic angina happens in younger patients. Their age would be less than 50. This is relatively younger patients. And the major risk factor here is smoking. It's not old age, it's not blood sugar, it's not hyperlipidemia, it's not any of the other factors. It is smoking. Therefore, when we're treating this disease, we advise smoking cessation. So the clinical picture of the patient would have recurrent chest pain that happens during sleep or rest, and it goes on its own in less than 15 minutes. The hallmark here, it's unrelated to stress. As you can see, it happens during whether sleeping or rest or any time, and it goes by its own. Of course, no infarction, no increased cardiac biomarkers, and here, if we do an EKG, it depends. If you do the EKG during the attack, you will see diffuse ST segment elevation. And the word diffuse here meaning it's in all the leads of the ECG. And this is different from STEMI because STEMI you would see elevated ST segments in certain leads, not in all of them. But here in the vasospastic angina, you see elevated ST segment in all the leads. If you do EKG outside of the attack, it would turn out to be normal because, as we said, it's only a transient vasoconstriction that goes on its own. So the treatment would be first smoking cessation, second calcium channel blockers or nitrates to vasodilate the coronary artery. Keep in mind that beta blockers here are contraindicated. And the reason here, if you block the beta receptors, which normally causes vasodilation, you actually worsen the condition by the unopposed alpha 1 receptors, which are already hyperactive, which would cause vasoconstriction and worsen the condition. And that's it for today. Thank you so much for watching, and please tune in the next episode because we're gonna talk about the second part of coronary artery disease in terms of complications, pharmacology, and talk more about the ECG changes. Please let me know your thoughts and comments about the episode, and thank you so much. I'll see you in the next one.